Another intervention that has been shown to be promising as it relates to neuroprotection is that of delayed cord clamping. When I did my training as a resident and a fellow in the late 90s and early 2000s, no one had begun to think about this, but this has really become standard of care again in the United States in the last 10 years. The American College of OB/GYN recommends delayed cord clamping among all preterm infants and points that there is neuroprotection by delayed cord clamping of the umbilical cord with a statistically significant reduction in interventricular hemorrhage. No difference. Actually, there was even a difference in sepsis that was seen that was difficult to explain. So the thing about these studies that led up to the conclusion that it was good to do delayed cord clamping in the premature infants is, what about premature babies who are not breathing upon delivery? What's the best thing to do there? Is it to deliver the baby and immediately cut the cord, clamp the cord, or is it better to deliver the baby and begin resuscitation while you wait the 60 or 90 seconds for delayed cord clamping to occur? So what we know is delayed is better than immediate early cord clamping for preterm infants if the babies are breathing. There have been 14 randomized controlled trials of preterm infants comparing delayed cord clamping versus immediate cord clamping. More than 600 preterm infants, immediate versus delayed. No difference in mortality, somewhat surprisingly, but what has been shown is less need for vasopressors and packed red blood cell transfusions, and less interventricular hemorrhage and necrotizing enterocolitis with delayed clamping. But non-breathing infants were generally excluded from these studies. So if the baby didn't look good, the default was to clamp the cord, cut the cord, and then begin your resuscitation. There have been preclinical animal trials that have looked at this concept that have been quite interesting. I'll draw your attention to the first graph on the top that has the red, green, and yellow lines. And what that demonstrates is preterm lambs who are born at the equivalent of 28 weeks gestation. And the way that they were resuscitated was they were delivered, they began to be ventilated, and then the cord was clamped at about 2 minutes of age. And what you can see in the red, green, and yellow line is how stable the cerebral oxygen saturations, peripheral oxygen saturations, and heart rate is maintained when the babies are ventilated first before the cord is clamped. In the second group, or the lower part of the graph, what it shows is the group of lambs who were delivered. The cord was immediately clamped, and then ventilation was delayed and begun at a couple minutes of age. What you can see is a precipitous drop in cerebral saturations, peripheral saturations, and bradycardia until the baby was, or the lamb was begun to be effectively ventilated, which suggested that in babies who aren't breathing, lambs who aren't breathing, it is better to prioritize ventilation versus the clamping of the umbilical cord. This study is actually being done right now in preterm infants, and Mayo Clinic is one of the study sites. And the intervention is our neonatology team provides ventilatory assistance, either CPAP or positive pressure ventilation, during 120 seconds of delayed cord clamping. You can think of the operational and logistical challenges of beginning the resuscitation while the baby is still connected to the umbilical cord, which involves our team being immediately next to the perineum while the baby is still connected to the umbilical cord, and we begin to deliver positive pressure ventilation, or if it's a C-section, being right next to the mom's abdomen while we wait the 120 seconds, begin to resuscitate the baby, versus the control group of standard 30 to 60 seconds of cord clamping, and then begin your resuscitation. The outcome of the VENT-FIRST trial is going to be reduction in ventricular hemorrhage on head ultrasound at 7 to 10 days of birth, and a secondary outcome reduction in other premature complications.